today to talk to you guys a little bit about the basic setup for some of the standard OB cases that you'll encounter. This first one will be a C-section setup. So one of the first things I do is I enter the core. On your right, you're going to see this warmer, and this is where they keep the warm blankets down here, and then the warm fluids up here. So as soon as I enter the room, I usually grab, you can either grab towels, some people like using towels, some people use the baby blanket. Personally, I grab two baby blankets out from the warmer, and then you create a roll. You guys will see this a little bit later. This is going to be our baby bump, so we'll show you that in a minute. And then I grab one of the warm fluids. So it's going to be a warm bag of saline over here. And then I carry them over to our bed. Your baby bump, usually it's nice just to kind of tuck it in over here. And we'll show you when to use that a little bit later. Just kind of put this off to the side so you don't forget about it. And then for your fluid, I'll put that down there. You're going to come over here to your cart. All the carts are 0, 9, 1, 1 to unlock. The second part of your IV fluid, your line is going to be down here at the bottom. I've opened a couple over there, so I'm going to use that. This is also where your blood pressure cuffs are if you need to use that also. And so you want to prime your line, make sure that you get all the bubbles out. Clamp it off. And then I go ahead and hang my bag over here. And you want to make sure that you can log into Epic. So once I've logged into the computer, you also want to log into the Pyxis. So those are the two big things that you also want to hit pretty immediately. Let's go through MS Maze. So machine, so go ahead and do your machine check as you normally would. Suction, I've got my suction down here. Of course, everyone has a different place where they like their suction, but just make sure it's working and it's easily accessible, whether that means it's shoved under here or in the canister. So machine, suction, monitors. The biggest things are obviously making sure that your EKG leads are set out, and many times they don't come with the leads or the pads themselves. So you can find the pads in the drawer here, or the EKG leads, as well as your pulse ox is going to be down here as well. So setting up your EKG leads, and then we've got our pulse ox and blood pressure up. Machine, suction, monitor, airway. So you should have at the beginning of the day your airway equipment already set up. So just make sure and take a look under the towel when you get in. Usually just make sure that you have everything that you need for airway. And then for the C-sections at least, most of us like to use a mask or a nasal cannula. So your masks, face masks can be found right on top here in this drawer. And then we just kind of hook it up and just set it to the side. And we'll talk about when you want to apply that mask. So machine, suction, monitor, airway, IV. So we already spiked our IV bag. All right, so for drugs, usually starting with the top drawer, you've got your Zofran. Sometimes they'll give it to the patients in pre-op. They'll give the disintegrating tablet, but sometimes they won't. But if you need it, that's the top drawer. You also have ephedrine. You may have to use some ephedrine. And then here's your Bicitra. And then you've got Reglan right here. And then here's our current spinal spinal dose of bupivacaine, the 0.75%. Occasionally it may be on back order and you'll have to use a different concentration, but that's what we're using for now. And the next drawer is going to be your phenylephrine. This is currently on back order for the sticks, so you may need to draw it up in a bag as we are doing currently. Here's your Ansef, and then here's the bags of PIT. We're currently using these bags of Pitocin. Some residents like to take out 1 or 2 bags at the beginning of the case and put it in the fluid warmer. Here's your basic setup. We've got your Bicitra, Zofran if you need it, Reglan. This is going to be injected into your bag of fluid over here. So once you've injected all 10 cc's of Reglan, you go ahead and slap a label on it and then put it into the pressure cup. So Reglan, we have 2 grams of Ansef. Remember, if your parturient is greater than about 120 kilos, they will likely require 3 grams, but here's the typical 2-gram dosage. Here's our phenylephrine reconstituted into a bag. So you take the 10 milligram, put it into 100, and that gives you a 0.1 milligram per cc or 100 mic per that you can draw out in your syringe. Here's your 0.75 of marcaine or bupivacaine. And then take out 2 cc or 100 mic syringe of fentanyl. All right, so now we're going to talk about setting up our tray for, this will be combined spinal epidural, which is what you'll mostly be doing with the C-sections. our other anesthesia cart, the code is 0911. At the bottom are all of our trays. So you have both a spinal tray, and then if it just says pain management tray, it's both a spinal and epidural tray. And you can also just, if you get kind of confused, you forget which one's the combined, you can see that it has both a spinal needle and it has an epidural components in them. So this will be your combined tray that we will get out. And then the gloves are obviously in this next drawer up. And then we have our fentanyl and our bupivacaine. Is to just tape these to the cart. As you open them, and just kind of tape them to the side of the cart. Obviously I'm not going to waste this, so you'd open it and then tape that to the side of the cart as well, so that you have access to both of them. Make sure you grab a trash can and then have a location that you can put your open gloves. You want to open this kit sterilely. So as much as you can, try to only touch the very outer edges. So you can kind of see there's these little tabs that you can pull on. You want to just open it very carefully, just getting the edges. And then do be aware of your medication. You don't want to accidentally flip your drape on top of your medicines that you've taped over here. So be aware of that. And then just carefully grab the edges here and open. So here's your Tegaderm. That'll be on last step. I take out this tray. This is going to be your cleaning tray. This syringe you don't need right now. And I usually take this little gauze pad out and use that separately. Here's your povidone solution. And I put that off to the side with this tray. They go together. Here's two drapes that you'll see that we use to help blot off excess solution. Here's your plastic drape. I like to put them in this order because that's the order usually you blot off and then you put on your plastic drape. So I like to put these in the order that I'm going to use them. Here's some labels, just generic labels for you. Here's your catheter that we'll talk about. It's for the epidural. You can go ahead and open that and set aside. Here's just more labels. Okay, so here's the basic contents of the combined catheter, or CSE. Get this out. You have your local, your 1% local. That's gonna be your numbing medication. You've got your sterile saline. This will be, if you use saline for the loss of resistance method, as I typically do, you can also use this at the end when you need to flush your filter. So that's an important one to have. Here's your glass plunger, or glass syringe. Typically, most often used with the saline solution for the loss of resistance, if you prefer saline. And here is a plastic plunger, most commonly used for air loss of resistance with air. Here is your epidural filter. You'll attach this onto the catheter. It helps filter out any impurities or bubbles. Here's your 22 gauge that you'll use for your local. So it's a thinner needle. Here's a filter needle, so the one with the white tip here. That's what you're going to use to draw up any of your medicine, especially your lidocaine, and then your spinal solution. And this is your, let's actually go with TUI first. This is the TUI needle, 9 centimeters in length. Each one of these is a centimeter. So when you are counting, when you lose loss of resistance, I usually go 9, 8, 7, 6, 5, 4, 3, 2, 1. So that's how you count backwards to figure out where your loss was. Another syringe. All right. And then here's our spinal needle with our stylet. So I'll just show you how I typically set it up. I usually open up my lidocaine first. You want, with this glass, the glass can break in fragments, can shatter onto the field. So I typically swirl and open outside of the sterile field and then place down. I typically use this 3 cc syringe with the filter needle to help draw up my lidocaine dose. So, I typically fill it pretty much all the way with lidocaine. Can't get enough lidocaine. Take any needle tip that you discard, put it into your sharps needle holder. And then you use the blue tip needle That's going to be for injecting our locals. So you can see that the needle is obviously much smaller. I typically just leave it a little bit loose and set it down so that way when I take it out I can easily withdraw the needle. And then I usually use saline, but for the purposes of this demonstration I'm going to use air for my loss and resistance method. So after you numb the individual, the next tool that you'll use is the TUI over here. So I typically take off, loosen the plastic tip, make sure that our bevel is pointing upward, which is aligns with this little cleft in the plastic. Make sure that everything moves freely and set it down. Here's our loss of resistance syringe. And then here's our spinal needle that we talked about. Again, make sure that the cleft is facing upward. And then lastly, I draw up my spinal dose. I usually take this, and sometimes lidocaine stuck in there, so just make sure you clear that. So assuming that we have our Marcaine open, or our bupivacaine open, I would then take let's say 1.4, I would drop 1.4 milliliters sterilely. So let's say that's 1.4. And then you take your fentanyl, and you usually do 20 mics of fentanyl. So it would be 1.4 to 1.6 cc's or milliliters of your local, of your bupivacaine, combined with 20 micrograms of fentanyl. And that on this syringe is going to be 2 clicks. So you see 1, 2 clicks. This is our spinal dose in here. Lay that down and protect the needle. I already took out my catheter, but that would come next. After our spinal dose, we would thread the catheter. And then this goes at the end of the catheter. I'll demonstrate that later. And then the filter goes beyond that. So that's kind of a basic setup. Again, unlike many other surgeries, we actually have our parturients, usually, especially the scheduled C-sections, walk in or waddle in as they may. The patient come over to the side of the bed. Usually your nursing staff will kind of help position the patient properly. At Parkland, we do begin with a 5-minute fetal heart monitoring. So we'll have the patient lay down, and the nurses will help put on the fetal heart monitors on mom, while you would obviously start your anesthetic record, get into the Pyxis, kind of get your basic, drugs out and the things that you need out, and then start applying your monitors. So we'll begin to do that now. So again, remember, just in general for anesthesia, generally pulse ox goes on the IV side, unless obviously there's 2 IVs, then you can't help that. So in this patient, we're going to presume that her IV is right here on the right side. So we'll place our pulse ox on the side. Remember to try to place it on a finger where she won't scratch her eyeballs out. And then we'll place our blood pressure cuff on the opposite arm. Okay, we'll relax. Remember to cycle. Usually you can start with a 3-minute cycle. Once we lay down after the neuraxial, it'll be important to change that to a 1-minute interval to monitor hypotension or sympathectomy response from your spinal anesthesia. We will also go ahead and hook up our IV. So make sure that your IV runs freely. Ensure that your IV runs freely before putting it in a pressure bag. There's nothing worse than if you have an infiltrated IV, applying pressure to an infiltrated IV. That would be no bueno. So once you know that your IV is running freely, then you may pressurize it, get all of this ready while they're monitoring baby. Then you'll head over to mom, and to perform the timeout, you'll obviously look at her wristband. Once you've done that, the nurse will help you sit the patient up during this part. But we'll get the patient up, sitting up. Obviously, you want to make sure that they're far enough back towards you to ensure adequate positioning. Make sure that the hips are aligned. You don't want one hip out of axis with the other hip. Obviously, that will cause a degree of rotation to be harder to find your midline. So once you feel, and also be wary, there's usually a break in the bed. Just make sure that for this procedure, they're not sitting on the break. Sometimes that can also affect the tilt of the hips or the rotation of the spine. So once you have found adequate positioning, then you would, before I get gloved back up, I will typically adjust the height of my bed. So you take your remote, where L3, L4, L4, L5 will be, and I probably lift it up to about slouch over or scrunch down, so not too high, not too low, just a comfortable kind of pushing height. The nurse will either prompt, or you can prompt for the patient to take the antacid devices. I usually, you can either put it over on your machine, or you can set it over. Before we start our neuraxial, typically the nurses will tell the patients to take it very fast. It's very sour. This is about the time, if your faculty is not already in the room, this would be a good time to text your faculty before you glove up saying that the patient's sitting up and that you're about to start prepping. Okay, so the first thing we're going to start with is cleaning the back. So this solution you want to open over, it's the povoiodine solution that we use at this institution is actually neurotoxic if it finds its way into the neuraxial space. So you want to open it always away from your sterile field. And then you can grab your tray, pour it again away from the sterile field. Alright, and then at this time I usually say, okay mom, I'm going to clean your back. You're going to feel some cold, scratchy solution on your back. And so you're going to take your tray, dip it, or take your sponge and dip it in your povoiodine solution. So, okay, a little bit of cold, scratchy solution here. And remember to go in circular motion from inside out radius. Toss it into the trash when you're done. Second one, take a nice amount of solution. All right, another cold, scratchy here on your back. Again, and one more cold, scratchy solution. The towel, same thing with this drape. Protect anything that's sterile. Dab, dab, dab with the back of your hands, and discard. Do it. The drape, again, is another thing that everyone opens a little bit differently. This is how I open it. I do partial like this. Gently allow it to unfurl. The bottom part's always going to stick. And then you try to find a space towards her skin that you can stick it onto. Sometimes that can be difficult, but if you try to do it with the gown can shift. So just be aware of that. And then you just tell her a little cold plastic drape here, and then carefully place it. Try to make sure that everything remains sterile. I will typically kind of tuck this under her bottom, just so it's not kind of flapping in the wind over here. And then usually at this point, I tell them that this is usually when I will, again, feel their anatomy. I usually feel before, like when I'm not sterilely gloved, and then also when I have a sterile glove, and this is when you can gently remind them to assume their position, which is a good time to talk about that position. So the best position for epidural, spinal, any of these neuraxial procedures are going to be one in which the parturient's shoulders are nice and relaxed down. Many times your nurse will be standing in front helping bring those shoulders down. We can tell them to tuck their chin into their chest and kind of roll their back down. And many times we'll tell them it's kind of like an angry cat, and to try to focus on putting the lower part of their back out towards us. And to imagine trying to open up the bones in their back is sometimes what I'll tell them. Sometimes they'll have the inclination to do this or that, and so it's important to tell them to try to keep this part as flat as they can, because a lot of them will think when you tell them to hunch over that they're going to lean forward as well, and that's obviously going to affect the angulation of your needle. So just focusing on a good C shape. Sometimes I'll pat this and say, push this part towards me, and that typically works, but you guys will all find your method. But just as Dr. Turner's exemplifying, just a nice rounded back here, making sure that her shoulders are level. A lot of times parturients can, especially if your hips are not well aligned, you'll find that their shoulders are slumping one way or another. So this is a good time to step back and make sure that the shoulders are both equal and level, that the spine is center or midline, that the hips are at the right angulation as well, that she's not over-rotated, she's not tilted too far forward or backward. This is going to be one of the most important steps that you can take, because the positioning truly is going to set you up for success or failure. So taking the time to really get that proper position, you'll find, is going to be key. We're fortunate that Dr. Turner has exquisite anatomy, and you can see her inner spaces without having to palpate anything at all. But for most of your parturients, they will not be this fortunate. So typically, for most of us, how we like to find the correct anatomical space is to start with palpating the top of her iliac crest. yes, many times this can be difficult to palpate, but you'll want to find kind of the top of the iliac crest or the top of the hips in colloquial terms, and that will be kind of your L4, kind of aligned with your L4 vertebra. So you can see with her, it's about the top of her iliac crest, and that's, you can actually visually see it. So there's L4, L5, L3, L4 right there. Okay, so already that gives you kind of where on a vertical positioning about where you should be. Now next I typically will try to find midline. So again, you can start with your vertebral prominence or C7. That tends to be one that many people can visualize. And then starting at the top of our sterile drape, a lot of times I'll try to palpate some of these thoracic spinous processes, especially if they're not as easy to palpate sometimes, or the lumbars may not be as easy to palpate as some of these more superior vertebral bodies. So whatever it takes, if you can palpate up or down, some, obviously in her case you can see and feel exactly where spinous process is, but if you need help you can always kind of start up higher and trace the back. L2-3, L3-4, L4-5 are all appropriate, but again, you're at risk the higher you go of encountering the spinal cord. So usually L3, L4, L4, L5 are going to be your safe spaces. Okay. Usually you'll see a lot of people that'll kind of press a fingernail in as an indentation so that they can figure out where they're going. A lot of times I'll just hold it and then get ready for my lidocaine injection. Okay. At this point we'll transition to the mannequin. So if this mannequin is Dr. Turner, if we found our space, the first thing that we're going to do is numb the area. So I always tell my parturients that that the lidocaine is kind of the worst part. It's a small needle, but the lidocaine burns and stings, and you'll see that when these patients first get their lidocaine doses, they're going to kind of wince. So usually I'll try to remind them that's going to be the worst part. So the best thing that you can do for yourself is make a good skin wheel. You're going to hear that term a lot, making a good skin wheel. How you go about doing that, again, everyone has a little bit of a different flavor on how they like to do it. Some people, I'll show a couple techniques. I'll go down here, even though that's not the correct space, just because so you can see. So some people like to start from here and superficially kind of inject. I'm not sure if you can see it on the mannequin or not. Some people like to go directly perpendicular, and when you're just right at the surface of the skin, you can inject and create a little local wheel. However you choose to do it, you should see a nice bubble in the skin, and that will be your skin wheel. And then I'll go up to the correct space. So once you've created a really good superficial skin wheel, don't be afraid to give them a nice amount of lidocaine, inject all the way into the interspinous ligament, because anywhere that your needle path is going to travel, they're going to feel that. So go ahead and if you would like to, you can aspirate at the end if you're concerned, but usually this needle length is nowhere near the epidural space, and so you can feel free to kind of liberally give a good amount of lidocaine. Some people like to do different angulations that helps them feel, if for some reason the spinous process was not easily palpable, some people actually like to use this as a finder needle to kind of angle in different directions, and you get a good sense of the ligaments as well as any processes that you might encounter if you were not able to palpate them easily. Which brings us into our next discussion, which are the layers that you'll be encountering as you perform this neuraxial procedure. So skin obviously is the first layer. The next layer is going to be the subcutaneous tissue. The layer after that is going to be your supraspinous ligament. So that is going to be the first kind of tough ligament that you'll encounter. And then you'll go through interspinous ligament. Interspinous ligament feels many times very bristly or like bristle. Many times you can hear it crackle. It should feel nice. For many women, it'll feel nice and tight. It'll be the first time that you'll encounter a decent amount of resistance. Okay, so, and I'll talk about that. I'll talk about that in a second when I introduce the TUI. After the interspinous, then you'll hit the ligamentum flavum, and that's typically what we describe as the pop sensation. And then after the ligamentum flavum, you're in the epidural space. After the epidural space, there's the durameter that you'll encounter before you encounter the subarachnoid space for the spinal injection. Those are the layers. And then I grab my TUI needle. The TUI needle, like I mentioned, is 9 centimeters in length. You want the bevel to be facing up, and that corresponds with this little divot, this plastic divot, so that you always want that to be upright. You want the stylet to be in place so that you're blocking any entrance of tissue or blood through the TUI needle. Like I said, each one of these is a centimeter, so be aware as you're introducing your TUI needle. Kind of be cautious and wary of your depth. If you have a very skinny parturient like Emily, and you're already at 8-9 centimeters, you might want to double check with the stylet to make sure that you have not crossed into the CSF space. So again, once she is properly numb, at this point I'll tell mom, okay, I'm going to insert the next needle. You should just feel pressure in the middle of your back. If it feels like more than pressure, if you feel a sharp pain or a stinging or a burning sensation, let me know, and let me know if it's left-sided or right-sided. I always tell patients that we don't have x-ray vision, that we're going off of anatomical landmarks, and so that she's kind of one of our, in addition to her position, the feedback that she gives us as far as if she's having pain sensation, that helps us guide our needle either left or right to the correct location. So that's important for them to know. So usually I'll say, okay, pressure kind of in the middle, pressure in the middle of your back. Now, as I mentioned, each one of these is a centimeter. For most parturients, you can insert probably a good 2 or 3 centimeters into the tissue, and you should be nice and seated. The goal is to be seated into the interspinous ligament. So that's going to be that kind of gristly ligament that you'll feel it's kind of tough. You should be able to let go of the needle and feel like it's securely in place. That is, if it's loose or floppy, you're probably in subcutaneous or you're off midline. So once you feel like your TUI needle is seated into that interspinous ligament, you remove the stylet, and at this point you would utilize whatever loss of resistance technique you have, whether it's air or saline with the glass plunger, and you would then attach it to the TUI needle. Once it's securely attached, you start testing to find what your baseline level of resistance will be. This is very difficult to teach. It's a very unique tactile sensation that you'll just get better and better at delineating over time. So it's going to be very difficult for me to describe it, but basically it should not easily give. If it's easily giving, you may be in sub-Q or off midline. It should feel like a nice fluid resistance. Now, you don't want to use too much force, because otherwise you're going to forcibly entrain air into spaces where it shouldn't be. But it should have like a nice little bounce. You'll hear people kind of talk about this little bounce sensation. So the next thing you're going to do is carefully, with consistent pressure, you're going to continue advancing your TUI needle while placing constant pressure in your plunger. Advancement of the TUI needle with constant and consistent pressure while also maintaining pressure on your plunger. Because if you forget to maintain the pressure on your plunger and you're advancing your TUI needle, then you may go past the space without knowing it. So, some air in there, we'll begin. So nice constant pressure with your TUI needle, so you can see that I'm advancing while I carefully am plunging down. And then you're going to hit a point where that plunger is just going to give. And that's going to be your loss of resistance, okay? So at that space where and you don't want to entrain too much air into it either. You don't want to put the whole, when you get the loss of resistance, you don't want to put all that air in there. But once you feel like there's a good give of air, that's your epidural space. So you'll remove your plunger, and then you'll pick up your spinal. So for the combined spinal epidural, remember, we've hit the epidural space. Now we're going to do a spinal dose with the spinal needle. If this was an epidural, we would stop and start threading the epidural catheter. Okay, so with the spinal needle now, this is also a different kind of an advanced technique that's going to take some time. I personally always keep one hand on the patient, one hand on the TUI needle while I'm advancing my spinal needle. So you're going to advance your spinal needle, and you're likely going to feel 2 pops, 1 to 2 pops. They're very distinctive pops, and the biggest piece of advice I can give is if anything feels like you're not sure if that was the correct pop, it doesn't hurt to just take out the stylet and check. So you'll very carefully, very slowly, while keeping your TUI needle in the same place, gently advance your spinal needle until you feel a distinct pop. Once you feel a distinct pop, I then I maintain pressure with my spinal needle and my TUI needle right kind of between my thumb and forefinger. I don't know if that's kind of hard to see, while also keeping a finger next to the patient. Again, I know it looks kind of complicated, but it's just a tactile sensation that you'll develop over time. And then I gently and carefully take out the stylet and observe for CSF. Now in this mannequin, we're not seeing CSF, but you should have a nice free flow of CSF backwards. And I basically wait until it's almost dripping out to make sure that you have adequate CSF flow, while keeping all of your components in perfect position, because the spinal space can be kind of finicky, and if you make any sudden movements at this part, you could unfortunately undo all the hard work that you did. So keep everything very, very still. Right before the CSF drips out, then you carefully place your spinal syringe on. Many people, I personally like to withdraw first before I inject. With the hyperbaric solution, the 0.75% bupivacaine, you should see a swirl of the CSF, which is just a nice visual indicator that you're in the correct spot. And then you carefully inject your spinal solution while vocalizing injection, so that everyone in the room knows that you have injected your spinal dose. And then in one smooth, some people like to at the end also withdraw just to make sure that they have good flow of CSF at the beginning and the end. So you're free to do that. And then you smoothly take out the whole component of our spinal needle while keeping our 2E in place. At this point, we're going to place the epidural. Now recall, so here's our catheter, our epidural catheter. And so quickly, the epidural catheter, the numbering on the epidural catheter, the dashes are in increments of 5. So the first one that you'll notice on this double dash, 5 times 2 is 10. The next one that we get to is this thick line, and that's 12. So 10, 11, 12, 13, 14, and then 5 times 3 is 15, 16, 17, I don't know, 18, 19 is not there, and then 20. So, like I said, the 2E needle is 9 centimeters, so 1 centimeter increments. What I typically do is I take the very edge here, I call that 9, 8, 7, 6. So you can see here I got lost at 5, okay? At 5 centimeters. So typically, again, there's a range. You typically want to thread your epidural anywhere from 4 to 6 centimeters to make sure that you, beyond that, to make sure that you are within the epidural space. The general rule, I think most people will say 5 centimeters. So take whatever your loss was, and in this case is 5 centimeters, add 5, so that'll be 10. That's where we're going to leave our epidural, okay? So you're going to go ahead and thread the catheter. You like to take this little plastic tip and secure it right there. It just makes threading the catheter a little bit easier. And then I typically find the end of the catheter and just kind of hold on to that, just because in this case, you just want to make sure that it doesn't, you have all this space here with the epidural catheter, just make sure it doesn't become unsterile. And then you're going to gently thread your epidural in through your 2E needle. And sometimes it doesn't thread that easily. There we go. So you're going to thread it all the way. So remember, 5 times 4 is 20. So we're at the 20 centimeter mark. You usually thread it just past that 20 centimeters. So then that way you know you aren't going to pull out the 2E and then lose your epidural. So once you've passed that, then you're going to advance the catheter while simultaneously withdrawing the 2E needle. Okay, so you want to make sure that you're not just withdrawing the 2E needle and then your catheter comes out. So slowly advance, at the same time withdraw. So advance and withdraw at the same time, and advance and withdraw. And then right when I see the tip, I usually just secure the catheter, hold it here at the back to make sure that you don't pull it out further. And then once it feels secure, then you can kind of just gather the slack. Okay, and then this is where we're going to pull out the catheter to the correct spot. So remember, our loss was at 5, add 5 to that, so we're going to go to 10. Okay, so this is 20. We should see 15 coming up right here, so 5 times 3, 15. 13, and then this big thick line is 12. 11, and so the next one should be 10. So I'm just going to leave right there at 10, okay? And again, you'll get the hang of it as you go along. So once it's in the correct spot, the next thing we do is we tape our alligator to the end, thread it, and then make sure that you have the catheter all the way to the back, nice and secured. If it's not locked in there correctly, you may have difficulty administering medications or withdrawing correctly. Once it's completely to the end and locked in, you want to clamp this down till it clicks, till it's nice and secure. The next thing we'll do is, we would take off the drape, and then once the drape is off, then we will secure our tegaderm and our catheter. Some people like to put a little loop in before you secure it. That just kind of helps keep it in place in case they should move around any. and then you get your little loop, put your tegaderm on there, and then we usually put it over, you'll see we'll put it over the shoulder of the parturient, take off the tegaderm, and then I always forget to do this, but right before we lay her down, she's gonna have that fetal monitor, and you just make sure that you put the band back up to secure it, lay mom down, and then that's it. Hey guys, it's Dr. Grunt again. I'm going to do a video for the bilateral tube, well, a spinal video, most commonly for the tubules. Refer to the C-section video for the majority of the setup. We're just going to briefly discuss how the setup's different for a spinal procedure. Most of these are going to be tubules, cerclages, sometimes a DNC. So the setup's going to be pretty much the same as far as our MS maids, machine, suction, our basic monitors, pulse ox, blood pressure, and then airway. Just make sure that you have your airway equipment under there. And then your IV fluids on a pressure bag should have some Raglan in it, just like the C-section videos. And then for your drugs, again, for most of our tubules, these will be postpartum patients, so they still are going to have, they're at risk for reflux, so they're going to need Bicitra. Some patients, if it's a DNC that's only 4 weeks, for example, that's not at risk for reflux, you may not need it, but usually it's a safe bet to have your Bicitra out. Some Zofran you may or may not need. They may or may not get it preoperatively. And then a syringe for your Raglan, which you will put in your IV fluid just like the C-sections. And then I also take out Versed and fentanyl. These would be, again, for your non-pregnant patients to help them with the spinal anesthesia. And then, of course, having a vasopressive or a vasoactive medication available. Most commonly, it'll be your neosynephrine or phenylephrine. Phenylephrine bag, but you may also have some ephedrine available if you need to. And then again, for airway, I like to use Seltzer nasal cannula. It allows you to monitor end-tidal CO2 with these patients, especially if you get Versed and fentanyl. But some people like to use face masks, but we'll leave that up to you. So that covers most of MS Maid's setup for this tubal scenario. For the tubules, most of the patients will walk in and will immediately sit on the bed. There's no need for fetal monitoring. So we kind of go, as soon as you put your basic monitors on, with the exception of the EKG leads, then you're free to proceed to your spinal kit to start setting up. So for the spinal setup, a lot of times, since you don't have the 5-minute fetal monitoring, you may be performing the spinal kind of as you go versus having it all set up like the C-section. However, I'll just set this up just because for learning purposes it's easier to kind of go through what your setup's going to be. Again, I like to set up in the order that I'm using my equipment. I usually take the gauze out of that tray first, and you know that your prep's going to come first. And then you'll dab the excess liquid, and then you'll don the plastic drape. So I like to put them over here in the order in which I'm going to use them. Have your labels. Okay, so the spinal kit, if you'll notice, one of the main differences between the spinal kit and obviously the combined spinal epidural kit is obviously there's no epidural catheter. You still have your 1% lidocaine, which is going to be your topical numbing medication. And then you have your introducer needle. And that will be the second step in the process after you've numbed them. And then you'll take your spinal needle. You'll notice it's very small, very thin. That's why you need the introducer needle, because this alone cannot penetrate all of the layers that you need to penetrate. Okay, and then they have a syringe for the actual spinal dose. Okay, so starting from the top, personally I grab this 3 cc syringe for our topical. You're going to use your filter needle to draw up your lidocaine. Here's your 1% lidocaine. Again, open the lidocaine away from the field to avoid any glass shards. And then we have our filter needle on our 3 cc syringe. And then go ahead and I usually just fill it all the way. Anytime you're going to put down a sharp, go ahead and put it in the sharps disposal. And then I attach the blue needle. It's going to be for your lidocaine. It's usually a 25 gauge. And I like to loosen the tip so that it's easily retrievable when it's time. And then you can go ahead, obviously, and label these if you'd like to, especially in the beginning, if you're afraid of mixing up your medications. And then we have our introducer needle. That's going to come next. And then our spinal needle. with the bevel facing up and the cleft facing up. And then we'll drop our spinal dose in the glass syringe. Okay. And then, again, for the spinal, this is typically 0.75%. The spinal dose is variable depending on the procedure and the attending. It can be anywhere from 1.2 to 1.6. You would draw up whatever amount of bupivacaine is required for this procedure. And then almost always 20 mics of fentanyl is what you would draw up, which is on this needle or on this syringe is going to be 2 clicks. So we will have drawn up our spinal dose, and now we have this kit set up. So first thing that we do, obviously once the patient is in the proper position, we open our povidone iodine solution. And again, we pour it away from the sterile field because it is neurotoxic and we don't want it to potentially contaminate our field. And then obviously inform your patient before we're applying this cold solution to their back. You say, okay, so I've got some cleaning solution here. It's very cold. Cold solution. I know, I'm sorry. And then again, circular motion from inside out near the area that we're going. All right, second cold solution, cold scratchy. It is for you. And one more cold scratchy solution here. Cold scratchy. All right, very good. All right, use this drape again, just like the C-section video. I want to make sure that you're not contaminating yourself or your field, and so I lightly dab it with the back of my hand. Like this, making sure to try to get in the middle so you don't have any more remainder than you need to. All right, then we're going to place our plastic drape. All right, we've got a cold plastic drape on your back. Make sure good contact. And I like to kind of tuck it in down here. Okay. And then this is where I like to reaffirm my anatomic landmarks, make sure that I have all of my equipment within reach so that if needed, you don't have to turn around and grab your medication, that you can keep one hand here and comfortably reach all of your tools and your medicines. All right, so usually I tell the patient, okay, now I want you to assume that nice position, relax your shoulders down, push your lower back out towards me, very good. And then remember, we go to, oops, sorry, just my hands here. We're going to find the top of the iliac crest, that's L4, and then try to find our midline position. Make sure that their shoulders aren't, their shoulders are even. If they're tilted too far, then maybe their spine will be rotated, or it'll be more difficult to find midline. So we're going to gently palpate midline, find our spinous processes, and then try to intersect that with our L4. And then go either L3, L4, or L4, L5, wherever you kind of feel a good inner space here. So in this patient, I would proceed to inject my local right here. Some people make a thumb dent to remind themselves. And obviously before you inject the local, be sure to inform your patient. So this time I'm going to move over to our standardized patient, Dr. Butts, over here for the remainder of the procedure. All right, this first medication is numbing medicine called lidocaine to help numb your back, but it does sting quite a bit. I'll tell you before I go. Ready? 1, 2, 3. And then remember, make a really good skin wheel. Obviously, you're not going to be able to see it on this mannequin, but a good skin wheel is kind of what we're looking for, making sure that you're covering all of the superficial areas, and then you can penetrate deeper and inject your local solution in all of the areas that you may be going. And so you can use, again, as we mentioned in the C-section video, you can use this numbing needle also as a finder needle, so you can kind of redirect up, down. If you feel a spinous process, you can remember that and remember to maybe have to go slightly superior to that location, or if you're running into lamina, you can figure out if you're off midline or not. So using it both for numbing and to help direct your needle course. The next step in this process is going to be using the introducer needle. We take our introducer needle and gently place it midline. And for most patients, you can hug this needle. Now, be careful if you do have someone who's exquisitely skinny, you may not be able to, so keep that in mind. But for most patients, they will do just fine with hubbing the introducer needle. It should feel nice and secure. So again, remember it's seated nicely into that inner spinous ligament, which is that tough bristly ligament. And then we pick up our spinal needle, bevel up with our indentation up over here. And very carefully hold the introducer needle and hold your spinal needle very gently and carefully. Advance. And on the spinal needle, you should feel 2 pops. The first one is that ligamentum flavum before the epidural space, and then the duramator, it's the tough mother. And then, there we go, pop, pop. And before we take out the stylet, you want to hold, if you can, hold both introducer needle and the spinal needle in place. The spinal injection can be very fickle, and advancing even slightly millimeter forward or back can potentially lose your location in the space. So carefully hold both of the introducer and the spinal needle in place while you remove your stylet and check for CSF. But if you are in the correct space, you'll slowly see CSF start to return out of your spinal needle. Once you see CSF and it just before it starts to drip down, you carefully grab your spinal injection and very carefully, again, without moving these, because again, any millimeter advancement or withdrawal can potentially lose the space, carefully attach the needle. Some people like to carefully withdraw. Oh, see, I can withdraw spinal fluid, yeah. Carefully withdraw it with the hyperbaric bupivacaine, the 0.75%. You can see a swirl here, and then you would inject your solution. And then at the end, some people also like to confirm with a swirl at the end. Once the spinal injection is completely in, you grab all of your components and in one fell swoop withdraw everything. All right, and then at that time you would set the patient down and attach your EKG leads, turn your blood pressure cuff to 1 minute cycling, and monitor for hypotension. I also just want to briefly touch on the signs and symptoms of a high spinal, since that is one of the more serious consequences of a spinal injection. So once you lay your patient down, again, cycle your blood pressure cuff in 1 minute cycling. Sometimes tachycardia shows up before the hypotension, so be aware of that and be alert for a brisk tachycardia, which may indicate that the hypotension is soon to follow. Profound hypotension occurs because of basically a sympathectomy, so you're hitting those cardiac accelerators from when it's higher than T1 to T4. Or your patient may complain also of a subjective shortness of breath, feeling like they can't breathe. If a spinal is starting to get too high, one of the things that you can check is hand grip to see if it's starting to affect T1, C7, you're starting to look at your cervical nerves as well. And then obviously any signs of CNS or cardiovascular disruption beyond that would be signs of, basically impending cardiovascular or respiratory collapse. So the patients will complain of they feel like they can't breathe, they may not be able to squeeze your hands, they may have numbness and tingling of the lips, things like that. It was truly a high spinal to the point where you're afraid of respiratory collapse. Your next step would be intubation and symptomatic support. So hope you guys found that these tutorials to be informative and helpful on your first day. Obviously, there's a lot of things that we didn't discuss that you will pick up over the course of the rotation. Obviously, the faculty members are always happy to help and reach out to them if you have any questions at all. And keep in mind that there's a bunch of different ways to do these procedures, but I hope this at least gives you a starting off point. So enjoy this rotation, guys.